everyone, to our Research Connect series. My name is Sarjana Alam, a CDTRP trainee at the University of Alberta. I will be facilitating today's webinar. First, I would like to acknowledge that the CDTRP is hosted by the University of Alberta, which is located on Treaty 6 territory, which is where I am today, a traditional gathering place for diverse Indigenous peoples, including the Cree, Blackfoot, Métis, Nakota Sioux, Iroquois, Dene, Ojibwe, Saulteaux, Anishinaabe, Inuit, and many others whose histories, languages, and cultures continue to influence our vibrant community. I encourage you to write your land acknowledgement in the chat box if you wish. We would also like to acknowledge Stellis, whose generous support we could not have had to host these sessions without. Before we dive into the main content, I will pass it to Erica for some general CDTRP updates.
Thank you, Sarjana. Today I have one announcement. Our innovation grant competition is officially open. CDTRP is offering $30,000 in seed funding for innovative projects related to donation and transplantation. If you are interested, you have until April 1st to submit your application. A link will be in the chat to learn more about this opportunity. That's it. Thanks.
Before I the speakers, I do have keeping notes. Today's speakers are credited on the CDTRP YouTube channel. In the presentation, keep your mics up. If you have a question, you can raise your hand with raise hand or type it. That I need to introduce the speakers after the scientific meeting. We are not done yet series. Benmassaoud is an assistant at McGill University Health Centre. His research focuses on addressing knowledge gaps. He's received several prestigious awards for his
Sarjana, can you try and, did you finish it? Sorry, I think it fully cut out on your end. Can you just read his Dr. Amine's introduction again, please?
Apologize for that. My mic working at the moment, or is
it's a medium. Keep trying.
That's my help here, and I hope that's perhaps improved my sound.
Yeah, that's great. That's fantastic.
Oh, perfect. Oh, so with that, I'll reintroduce Dr. Benmassaoud. Sorry about that. So I'm pleased to introduce Dr. Amine Benmassaoud for today's annual scientific meeting. We are not done yet series. Dr. Benmassaoud is an assistant professor at McGill University Health Centre, specializing in hepatology and portal hypertension. His research focuses on addressing knowledge gaps in vascular liver diseases, and he has received several prestigious awards for his work. With that, I will hand it over to you, Dr. Benmassaoud.
Hi, everyone. Thank you, Sarjana, for the introduction. Seeing it's a nice little cozy group. I recognize some of you. Hi, Chris. Hi, Tanya. And so if, please don't hesitate to interrupt me if you have any questions as I go through the presentation. So I hope everyone should be seeing my slides for today.
Yep, looks good.
Yeah. All right. Awesome. Thank you. Okay. So today I'll be discussing the results of a systematic review and meta-analysis that we've conducted on the topic of prehabilitation before liver transplant. These are my conflicts of interest. I do want to mention that I have received a CDTRP funding as well as CASL funding to investigate the effects of multimodal prehabilitation in patients undergoing liver transplantation. So the objectives of today, so we'll first start by describing what we call sort of the burden of whole person determinants of health in patients awaiting liver transplant. We'll discuss current knowledge on prehabilitation programs. We'll then present the results of our systematic review and meta-analysis and expand on current unmet needs and potential future directions. So as some of you may know, in Canada, livers are allocated based on highest medical need, and we use the model for end-stage liver disease for this. This is a combination of INR, bilirubin, creatinine, and sodium, some easily obtainable blood tests. The MELD score, what it does, that it allows you to predict a 3-month mortality of patients. So the higher the score, the more likely, unfortunately, they are to pass from their liver disease. In Quebec, the median MELD score at liver transplantation is around 25. So it's basically based on this graph, there's about a 20% risk of dying in the next 3 months. There are exceptions to this rule where we do add additional points for HCC, so that's liver cancer, or other rare diseases that might not be well accounted for by the MELD score. So despite us using this system, there's still about 10 to 20% of patients that die while waiting liver transplant, and this is based on some Canadian data. And so this is where sort of the whole person determinants of health are going to come into play. And so here specifically, I'm going to be talking about malnutrition, sarcopenia, and frailty. This was a beautiful review that was recently published by Dr. Punita Tandon and Jennifer Lai. So of course, when we look at patients with liver disease from a hepatology point of view, we think about the synthetic dysfunction, so the ability of liver to produce certain, to carry its normal function. There's the fluid retention seen as ascites, cognitive dysfunction based on with hepatic encephalopathy. But there are also many other components, such as systemic inflammation, physical inactivity, but also environmental determinants, which might lead to and contribute to malnutrition, which is seen both due to inadequate intake or uptake of macro and micronutrients. These things together might manifest as muscle dysfunction, specifically through phenotypes of frailty or sarcopenia. And then all these things together lead to worse health outcomes, including higher risk of decompensation, healthcare utilization, decreased quality of life, death, and adverse events post-liver transplant. When we look at malnutrition, the prevalence of malnutrition definitely increases with worsening liver disease. The Child-Pugh score is a score that we commonly use to a great degree of synthetic liver dysfunction. And so patients with a Child-Pugh score C, which is the most severe form, will have nearly a 95% chance of being malnourished. Considered at higher risk will be those that have had decompensation in the past, so ascites formation, variceal bleeding, or hepatic encephalopathy, Child-Pugh score C, or if their BMI is below 18.5. There are some rapid screening tools that can be used, such as the Royal Free Hospital Nursing Prioritization Tool, or in-depth assessments, such as the different forms of global assessment, such as the RFH-GA, the subjective global assessment, or the patient-generated SGA. When we look specifically at patients awaiting liver transplantation, obviously these are selected individuals. The prevalence of malnutrition hovers between 45 to 65%. And malnutrition, as you can expect, is associated with worse outcomes, both before and after liver transplantation. Before liver transplantation, it is clearly associated with an increased risk of death while on the waiting list. It's also associated with increased risk of bacterial infection after liver transplant, increased need for mechanical ventilation, so being on a ventilator more than a day after liver transplant, and also having a prolonged ICU care, which was here defined as sort of 5 days after liver transplant. Moving on to sarcopenia. So the overall prevalence of sarcopenia based on meta-analysis of around 7,000 patients with cirrhosis seems also to hover at around 37 or 40%. And here again, there's some key things that predict higher risk of sarcopenia. So again, the Child-Pugh score, I'm talking about it again, or a Child-Pugh C score. Patients have higher risk of sarcopenia, nearly reaching 50%. Male patients seem to be more at risk, and also those with alcoholic liver disease, which again might be related to both the intake and the uptake of the nutrients. Sarcopenia is associated with worse outcomes both before and after a liver transplant. So when we talk about before liver transplant, there's a clear reduction in survival, whether or not patients have liver cancer. And the reduction in survival, on average, seems to be reduced by about a year. After liver transplant, again, so patients with sarcopenia, here highlighted in blue, will have a higher risk of bacterial infections, major complications, but also an increased risk of dying within the first year after transplant. They also stay in the hospital about 15 days longer, again, going into both the complication risks and the increased healthcare utilizations. And to finish off in these whole person determinants, I'm going to talk about frailty. So frailty in patients with cirrhosis will be, there are different ways to assess it. The liver frailty index is the most commonly used. And that combines the dominant hand grip strength, the time to do a 5-chair stand, and seconds holding a 3-position balance. And this has been validated for males and females separately. The good thing about this is that it's very well validated and categorizes patients based on the degree of frailty, so either as being robust, pre-frail, or frail, and it has a very high inter-observer reliability. Once again, and I'm sure you've noticed a theme here, so the prevalence is somewhat variable, but it again seems to increase with worsening liver disease. More people that are decompensated seem to be also more at risk of frailty, such as patients with ascites or hepatic encephalopathy. And in here, as you can see, so in blue, different cohorts will show that maybe female patients might be more at risk, people with fatty liver, whereas interestingly, people with liver cancer, so HCC, seem to be more at risk of frailty. And I think this is probably more likely related to the type of patients with liver cancer that make it on the waiting list, as opposed to those that are not on the waiting list. Regardless, at the time of liver transplant, patients with frailty tend to have a higher MELD score. They're more often in need of a combined liver transplant with a kidney. And this seems to be independent of age, which does not seem to play a major role here. In terms of outcomes, again, frailty is associated with worse outcomes, both before and after a liver transplant. What was interesting is people going into a liver transplant that are frail are more likely to remain frail post-liver transplant. And these patients, again, seem to have a longer ICU course, longer hospital length of stay, and are more likely to not be discharged home to a rehab facility. This is not just in patients with liver disease. When we look at surgical outcomes and frailty, and this is including 16 clinical trials looking at any type of OR, and here they used the modified frailty index. Frailty was associated with higher mortality, higher complications, reoperation, failed discharge, and readmission, as shown here. So this is where the concept of prehabilitation is very interesting, especially before elective or semi-elective surgery. And this is where we'll be using a window of opportunity for targeted interventions while patients are waiting. And prehabilitation can be considered as unimodal or multimodal, depending on use of either backbone of exercise, nutrition, or psychotherapy. When looking at the surgical literature, before I start talking about liver transplant setting, there's been a recent systematic review that was published about last year. Again, 25 RCTs between 2006 and 2023, about 2,000 patients in total. And here I think it's important to note the average duration of these programs was only of 30 days. A lot of the reasons for that is those were often for oncological type surgeries, where there's obviously a need to operate sooner rather than later. So in the 25 RCTs that were identified, 2/3 of them were unimodal, mostly consisting of exercise, and about 70% followed by nutrition and psychotherapy. Multimodal, again, consisted mostly of a backbone of exercise, where nutrition would be added on as well. When looking at the results, unfortunately, there was no difference in post-op complications. There was also no definite reduction in the total hospital length of stay. There was maybe a small trend towards reduction in time spent in the ICU. Now, obviously, these are programs that were highly variable, targeted different types of population, and where the prehabilitation program tended to be quite short, of only 30 days, which could also explain why they might not have seen any big changes in post-op complications. If we're going to talk about patients awaiting liver transplantation, so as I've already described, there's a high prevalence of malnutrition, sarcopenia, and frailty. There's clearly associations between these and worse outcomes both before and after liver transplant. Liver transplant is a huge stressor, as you can imagine. It's surgery that lasts about 6 to 8 hours, where people are often hospitalized for about 2 weeks after. But it's still considered elective in a lot of cases where patients are actually called from home to come to the hospital. But one of the biggest obstacles that we face in thinking about prehabilitation is that we often only know about a liver transplant happening within 24 hours. So it's really hard to predict or plan in this context. Regardless, there is some data out there, and we've published a scoping review within the last year, and we really focused mainly on exercise. And we had identified about 6 studies, including 2 RCTs and 4 prospective cohorts, with a sample size ranging between 13 to 33 patients only, so quite restrictive. And also the exclusion criteria were highly variable from one study to the next, showcasing a highly selected type of population. And here the duration of the intervention tend to be longer than we would see in other surgeries, with a duration between 6 to 12 weeks, so basically reaching about 3 months. The setting of the exercise session tends to be either in the hospital for outpatients or at home, or a combination of the two. And it was often backbone of aerobic type training plus minus resistance training. And the frequency of the session tend to be between 2 to 3 sessions per week. And here only one session, unfortunately, sort of offered nutritional optimization as per protocol. And we looked at recruitment, study completion, and adherence, again, highly variable between 20 to 60% of patients that accepted to participate in the study. About 40 to 90% completed the study. Adherence, again, used various definitions from one study to the next, but this hovered between 50 to 100%. And there seemed to be some trends or some possible improvements in peak oxygen consumption as determined by CPET or cardiopulmonary exercise testing. Also improvements in potentially in 6-minute walk test, as well as muscle strength. One study was able to show a potential trend in reduction in post-liver transplant stain. So when we thought about it, we really were wondering, if we expand just beyond exercise, and we're going to look at also nutrition and psychotherapy, are these programs feasible? Are there differences between feasibility between each of these modes of prehabilitation? Is prehabilitation safe? And are we able to drive changes or improvements in health-related outcomes? So this is what we're describing today. So these are the results of the study that we'll be presenting, which looked at the feasibility, safety, and effectiveness of prehabilitation programs in patients awaiting liver transplantation, systematic review, and meta-analysis. We followed the PRISMA guidelines, and we've registered our systematic review on Prospero. And so these are the study inclusion and exclusion criteria. So we looked at single-arm or comparative arm studies, but had to be prospective or randomized controlled trials. These had to be patients that were actively listed for liver transplant or undergoing workup for listing. And we did not restrict in terms of the type of prehabilitation, could be unimodal or multimodal. And as long as the study described feasibility, safety, or effectiveness endpoint, they were considered for inclusion. We've excluded studies that dealt with pediatrics population, retrospective studies, hospitalized patients. We've excluded studies where the listing status of patients was unclear. And we also excluded studies where there was an unstructured program. We used the following databases, and the search was constructed by a health science librarian. The date of the last search was in April of 2024. We've applied no language restrictions, and we've used cross-referencing to identify potential other includable studies. Data was extracted by 2 authors, and discrepancies were addressed by a 3rd one. And we've looked at feasibility data, including study participation, study completion, safety, including adverse events, deterioration of health. Effectiveness, we've looked at specific metrics, including peak oxygen consumption, maximal power, 6-minute walk test, liver frailty index, hand grip strength, and mid-arm muscle circumference. And we tried to look at post-transplant data where available, including duration of hospital stay, ICU, and death. So we've conducted both a proportion type meta-analysis and also a comparative meta-analysis, reporting both 95% confidence intervals as well as odds ratios, and odds ratios for outcomes that were more categorical and continuous. Outcomes were analyzed using a standardized mean difference. We've looked at heterogeneity and conducted subgroup analyses based on the type of interventions. So in terms of the results, so we used 5 databases. We were able to, we screened 2,844 studies. 95 of them were assessed for eligibility. 24 studies were included, but only 20 had analyzable data. And so this is the breakdown of the studies that we were able to identify. So 19 were unimodal and 1 was multimodal. And the multimodal one combined nutrition and exercise. When looking at unimodal studies, there was pretty fair split here between exercise and nutrition, so nearly a 50-50 split. And so these are all the studies that we've included, divided based on the type of study, whether it was prospective or randomized controlled trial, the type of intervention, and whether or not there was a control arm available. So in looking at a recruitment, and I think it's a really interesting endpoint because as we try to identify patients to participate in our studies, there are obviously inclusion-exclusion criteria. And then once we've approached patients and try to discuss it with them, patients might say yes or might say no. And this sort of looked at all the patients that met the inclusion-exclusion criteria and were approached to participate, and how many actually said yes. So 12 studies provided such data. About 1,120 patients were available. So at the top here, we're looking at exercise studies. Looking at exercise studies, there are about 6 studies that were included, total of 343 patients. Looking at random effects model, the overall recruitment rate was about 57%, hovering between 20% in one study to 100% in another one. Looking at psychotherapy, unfortunately, we only had 1 study that offered this data with around 24% recruitment. And then when we look at nutrition studies, here we had 5 studies. The recruitment was around 79%, and there was differences both between the interventions, suggesting that maybe even from nutritional studies, there was a bit of a higher rate of recruitment compared to the others. At the end of the day, we're looking at all the studies, about 66% was the overall recruitment rate. Looking at program completion, again, it was interesting to see differences between the different types of interventions. Again, so here for exercise, here we had 7 studies, and around the 7 studies, the proportion of participants which completed the program was around 65%. For psychotherapy, we had 2 studies, which was around 54%. For nutritional studies, was around 88%. And again, there was some important differences between the subtypes of intervention, again, with nutrition suggesting a higher rate of program completion. For multimodal, as I mentioned, we only had 1 study, and so it's hard to draw any conclusions based on that. Overall, looking at program completion, the average was around 75%. That was the pooled proportion. What was interesting is that when we looked at completion of the program, there didn't seem to be any major differences between the control group and the intervention group. In terms of adverse events, again, divided between exercise, psychotherapy, and nutrition, here being 0%, really very, very safe intervention. We're looking at exercise, we're looking at maybe like a 5%. And here we're talking about adverse events related to the intervention itself. So again, very safe. Here, there was no heterogeneity between the different interventions. And there was no difference between the intervention arm and the control arm in terms of adverse events. When looking at exercise metrics, or not just exercise, but also frailty, hand grip strength, and mid-arm muscle circumference, and this made it a bit harder to analyze. As you can tell, these are the studies that had available analyzable data for this. And it was very heterogeneous in terms of what studies were reporting. And obviously, studies that did not have a comparative arm, we could not include them for the comparative studies, for the comparative analysis, sorry. So when we look specifically at the intervention arm, when we look at pre versus post, so people that go through the prehabilitation, whether for 6 weeks or 12 weeks, and then we look at the results after they're done the intervention. We were able to show that looking at peak oxygen consumption, peak power, and 6-minute walk test, based on 3 studies, there was a significant improvement compared to their status at enrollment. Liver frailty index, 4 studies, there was a reduction in liver frailty index, which is what we want to see. The lower the frailty index means the lower the frailty, the more likely for patients to be robust. We could not see any big difference in terms of hand grip strength, whether we divided based on studies that were dealt with nutrition, exercise, or overall when combining the two. When we're comparing with the control group, so here we're looking at end of intervention for both the intervention arm or the control arm. We noted differences in the peak power as assessed by the CPET, and also for the mid-arm muscle circumference. The peak VO2, so peak oxygen consumption, really was very close, or really tended towards significance, but didn't quite make it. And unfortunately, there was no difference with liver frailty index and hand grip strength for the two, which might also owe to the differences in both groups where they were starting off in terms of frailty or hand grip strength. When looking at outcomes post-liver transplant, we did not note any difference in terms of death, total length of stay in the hospital, or ICU length of stay. So just to wrap up in terms of discussion, we were able to glance from all these, looking at all these studies. So ease of recruitment and program completions were highly variable. And when we look at the nitty-gritty in terms of the program duration and the program setting, we didn't really pick up any major signal in terms of match between, shorter programs maybe being easier to recruit, or those with less frequency of study visits. We couldn't really see that. Addition of incentives was not always successful, and here whether it was through motivational calls or even through monetary incentives, this did not seem to translate with increased adherence. And it did seem a bit higher or easier to recruit or to have patients complete the program in nutritional studies. The intervention did appear to be safe, and that's across all types of intervention, but it's important still to note that the participants were highly selected and so might not actually represent all patients awaiting liver transplant. But not only that, there's a lack of reporting of deterioration of liver disease or program interruptions in these studies. Most of them really focused on adverse events related to the intervention itself. I am saying that prehabilitation is likely to be beneficial. I mean, there seems to be changes, at least in pre-post metrics, as I've described, especially in peak oxygen capacity or peak power. whether studies of nutrition alone would be able to tilt the balance and improve hand grip strength or reduce frailty, I think that still needs to be seen. And there's quite a lot of uncertainty that remains, especially when we compare to a control group where we might not, where we did not note, in our systematic review, any major changes in frailty or hand grip strength. Could that be because of patient selection? Should really be focusing on more frail patients when we're recruiting into our studies? It's hard to draw any conclusions differentiating unimodal versus multimodal because we could only identify one study as part of our systematic review. And the other big one in my mind is the sustainability of these improvements. Why am I bringing this up? Because a lot of our patients might finish the programs as set up in the studies. For example, if it was a 3-month study, but some patient will wait on the transplant list for 6 months before they get offered an organ. So whether or not these improvements that they've noticed or that we've noticed are maintained throughout to the time of transplant, I think that remains to be seen. Very well might be that patients actually might get weaker or might be frail again if there's a long gap between prehab and the time of the surgery itself. And there's a lot of things to consider when we're designing a prehab study. Patients awaiting liver transplantation, and I think that's a really great review again by Dr. Pranita Tandon, where these patients have complex medical needs, whether it be the fluid overload such as ascites, chronic pains or anemia, which might be limiting exercise capacity. There's also fatigue or daytime somnolence, which can be seen in patients with hepatic encephalopathy. And a lot of our patients are on beta blockers, which reduces exercise capacity. There's also uneven needs, which need to be optimized, as I mentioned. So there are varying degrees of sarcopenia, varying degrees of malnutrition, and also of physical inactivity or reduced aerobic capacity. There's also a big thing where we need to break the sick rule for our patients where, unfortunately, because they might have had liver disease for quite a long time before they end up on a liver transplant list, there can be lack of motivation, lack of confidence in terms of being able to participate in exercise programs. We need to consider our patients in their whole context. How far do they live from the hospital? Do they have any good social support system or things that would allow them to participate in prehab programs, which again, might not be feasible for everyone. And also we have to bridge the gap with clinicians, which have reported lack of expertise or lack of confidence themselves in terms of prescribing exercise or nutritional optimization patients awaiting liver transplantation. And I think we still need, again, to reinforce only the safety of this intervention. In terms of future direction and unmet needs when developing these studies, I think it's still really important to determine a core set of outcomes where we can all speak the same language, where we're all going to report the same stuff. Is it going to be a 6-minute walk test, which will be might be a bit easier? Are we going to use cardiopulmonary exercise testing, which might allow us to identify small changes in maximal power or peak oxygen consumption, but might not be feasible in all centers? I do believe liver frailty index should be part of standard prehab studies because it's well correlated with outcomes. And I think we still need to identify the optimal components and mode of delivery. Are we going to only include patients that are actively listed? Are we going to allow patients that are being evaluated for listing? And are we going to combine exercise, nutrition, and or psychotherapy to really favor a multimodal approach? And we're sort of still in, like I said, the who, what, where, and how. And especially with everything happening after COVID and being able to reach more patients, I think the role of virtual delivery of prehabilitation is going to take more and more space. And I think considering all this, we still might see changes in terms of how feasible it is, our ability to retain patients and for them to adhere to the programs. And we still need to develop, I think, with patient partners, different incentives actually that would work best for our participants and people, patients that are awaiting liver transplants. And I think down the road with enough retrospectoscope, I think being able to look at the impact of our intervention, both on pre and post liver transplant outcomes. But I think this will take a while before we can have enough data to be able to support that. And I did want to finish up with talking about two ongoing studies. Really great stuff happening with Dr. Punita Tandon and Chris Cruz, looking at a 12-week of online prehabilitation program for patients with cirrhosis awaiting liver transplant. It's a CIHR-funded multi-center Canadian RCT with a 2-to-1 allocation to the fantastic Heal Me platform, looking at multimodal prehabilitation with nutrition, exercise, and also life skill modules. And also we have our study at McGill, which is, as I mentioned initially, which is a CASL and CDTRP funded trial, looking at 6 months of prehabilitation, looking both at induction and maintenance, multimodal prehab combining nutrition, exercise, and here we're looking at high intensity interval training, but also anxiety and stress reduction. And we'll also be looking at feasibility, adherence, safety, but also changes in exercise, nutrition, and quality of life. And we're glad to see that our recruitment is completed, and we're just going through patients that are going through the intervention. So take-home messages, I think I was able to convince you that sarcopenia, frailty, and malnutrition have a massive impact on the health trajectory of our patients awaiting liver transplant. We all hope that addressing these issues hopefully will lead to a reduction in poor outcome. I truly believe that prehabilitation holds promise in this field, but that our approach still needs to be individualized and supported by a multidisciplinary team, and that future research in this field is still awaited. And thank you. I don't know if there's, thank you for your attention. I'm really open to questions, comments, and obviously any collaboration.
Thank you, Dr. Benmassaoud, for that excellent presentation. As you mentioned, we would like to open up the floor to any questions. It seems that people are perhaps taking a few moments to type their questions into the chat, so perhaps I can start off. Or I do see that Tammy has a question, so I'll let her go ahead.
But go ahead if you want to ask before me.
Oh, thank you very much. Dr. Benmassaoud, you addressed that one barrier to the feasibility of these studies might be that current strategies for making the studies or the rehabilitation programs more accessible to patients, such as shorter duration or incentives, are not sufficient at the moment. You mentioned that virtual programs might increase their ability to participate. Are there any other strategies that you might suspect to help with that?
Yeah, so I really think that being able to offer flexibility to our participants and our patients down the line is what's going to be critical. As you know, we are a liver transplant program. We care for patients that live 10 minutes away from the hospital to patients that live 6 hours away. And I think we want to be able to reach as many patients as possible as they're awaiting liver transplant. And I think offering that flexibility to the patient will boost feasibility, will boost adherence as we try to cater to them. And I think having different interactions and having different patient representatives from different stakeholder groups would optimize the way we plan and think of these interventions. Now, whether the benefits or whether the impact of the intervention will be the same if it's in person versus virtual is another question. But I think obviously we need to investigate that further.
Thank you very much for that answer. I'll pass it off to Tanya again.
Thank you so much. Thanks, Amine, for the presentation. I really enjoyed it. It was nice to see the results of the systematic review. I'm wondering, I think we discussed that a little bit during the outcome measure meeting that we had with Restore. But you didn't find difference in frailty, hand grip strength, and VO2 peak when was compared to controls. Do you think that, or did the studies include other type of outcomes, for example, physical function outcomes, 1 minute sit to stand? I'm just thinking that depending on the type of training that and I'm sorry, now I'm talking more about the exercise-based interventions.
Yeah.
Depending on the type of training that the patients were able to do, because sometimes you have a protocol and they're not able to actually follow the protocol, we wouldn't see any difference in VO2 max or peak or hand grip strength, because let's say they're doing more lower body exercises. So do you think there is a gap in terms of type of outcomes that these studies are including? Or I don't know if you think that they included, but it was not the outcome you were interested in the
Yeah. So it's a great question, as always. Nice to see you, Tanya. When we look at these studies, and I tried to show it in that table where there's different studies, but there's so many different outcome measures, and then especially if you look at the publication year. There'll have been an impact on whether or not, for example, the LFI was used. And I think now more and more all studies will start using the LFI standard. I think because we had studies from the early 2000s, LFI was not available back then, which can explain one of these limitations. And I think you're right. I think for clinicians and investigators, when we're proposing an intervention, we have a hypothesis in terms of what we expect it will have an impact on. We want to show positive results, right? And so we will choose outcome measures that we're most likely to be able to be positive. And especially if you're doing that in a hospital setting, or have patients come in more often, and if you have the setting, we have seen CPET being used. CPET, even like little changes, even little changes in CPET, such as peak oxygen consumption or max power, seem to have physiological impact when looking at post-transplant outcomes, which I think that one of the reasons why that's interesting. But I don't think that CPET is something that we can do everywhere. And I think we should focus on things that we could speak the same language. And I agree, if we're thinking about a nutritional intervention, we wouldn't really expect that nutrition alone might improve like our CPET or exercise capacity besides, if it's not combined with exercise. Yeah. Chris, I see your comment. I completely agree with you. Completely agree with you. And I think that's it's underappreciated at the moment. It's underused, both qualitative and quality of life type measures as well.
Yeah, I just wanted to comment there because I'm leading the qualitative side of the OPAL study prehab program. And I think that a lot of the patient experiences are masked by the deterioration of their liver. So, if your outcome is a sit to stand, you might get them on a bad day, and the sit to stand outcome is not necessarily good. But the qualitative interviews that we've conducted, people are able to show that, yes, this prehab program, I'm able to open a jar now, which, that's not going to be captured in a number from the sit to stand test, right? So I think that these qualitative outcomes will really support prehab programs, just to not that we're just looking at the numbers, the difference between base start and end, but just what patients feel about the prehab programs. And we get a lot of positive feedback, and at least from the patient side, like they believe it's an integral part of the system, the transplant program, that we're missing.
Yeah, I completely agree with you. And I think you mentioned a really important point, like, when you do the assessment visits, sometimes it'll depend how they are that day. And we've seen quite a bit of variation as well in our study, because we've had 20 patients that have completed the study, and we also notice these variations. I think acceptability was really important. So that's one of the things that we also did. We hope to publish on with our study that we're doing, looking at reasons why people did not participate. because for us it was an in-person type program, right? People had to come to the hospital for the high intensity interval training. And some patients, part of our transplant list, are still working, and they might not be able to integrate or participate. But we also had sort of acceptability questionnaires in terms of what they thought worked well, what didn't work as well, so that we can, tailor it and really aim for satisfaction, which I think is also a very important point, to feel that they're empowered, because a lot of things that happen with deteriorating liver disease is people feel powerless and that they've lost control over their health trajectory.
Can I just make a quick comment? I think it's related to what Chris commented, and also going back to the outcome measures. I think also what would determine which outcomes we should be using in clinical trials is what our goal, right? What do we want to show or get from the prehabilitation intervention? Do we want them to increase their quality of life and be able to do more things during day-to-day life while they're waiting for transplant? Do we want to show that this exercise or nutritional interventions will actually have an impact, will change the sarcopenia, because you show there that this is what it's related to, all the bad outcomes. And do we want to change sarcopenia to then have an impact on post-transplant outcomes? In my opinion, I think, of course, we want both. But the way we design this study and what is the main goal of the research, it will dictate which kind of outcome we should be using. So I think it's hard to show what the impact post-transplant, the mortality or the healthcare utilization. I think this is harder to show. It's easier to show if they are doing better while waiting for the transplant, I think.
Yeah, and that's why we're trying to use these surrogate markers as predicting that if your 6-minute walk test is better, if you increase your peak oxygen consumption by 1 milliliter per kilogram, that you're going to do better post-op. Yeah.
I do see that Sean has his hand raised.
Hi, great presentation. I'm Sean Delaney in Edmonton at the U of A. But something that's come up on some of our seminars in both the prehabilitation and the post-transplant rehab side of the equation is the discussion about offered versus prescribed when it comes to things like being on the wait list. Acknowledging things need to be very, very personalized. Your diagnosis and your liver status and things like that is very, very individual. But when it comes to, I know a lot of you already know this, but I'm also a transplant recipient myself, but kidney. So I'm curious in Donna's thoughts on this as well. But in many cases, when we're sitting on a wait list or things like that, some of these programs get offered to you. I mean, I was on a dialysis unit, they put a bicycle in front of you and said, would you like to be part of such and such a study, versus the alternative of, for the best outcomes, we have a lot of evidence here growing in nutrition and exercise that we think it should be recommended for all. And like to that point of, our program prescribes, to the extent possible with your individual capacity, would this, how would you and some of the studies you looked at view that thought? It is a tough one because prescribing is moving from, a choice to, well, it's always a choice, but now it's a medical opinion, and sometimes your spouse heard it and says, no, we're doing it, or versus a study that you just sign on and say, yeah, I'll come.
Yeah, thanks, Sean. Thanks for sharing your thoughts. I agree with you that there's definitely there's a difference there between the offered and the perceived, and I think that's where we have to bridge the gap with clinicians, and I think that's a very important part of that equation, because of, unfortunately, not every physician, clinician feels comfortable offering these things, right? And so we were lucky to be recipients of the CDTRP grant, really, super lucky, where we were able to, for the first time, offer this at our institution. Right? And before that, it wasn't offered, and it probably maybe was not prescribed either. And I think there's even from clinicians, a lack of comfort in terms of prescribing these. And we do have to take into consideration many variables when it comes to individualizing that for our people on the
For
waiting.
sure.
Yeah.
Yeah. I, because I'm here at the U of A, I see a lot of the heart patients and things like that who are literally prescribed the post-transplant rehabilitation, and there's not a lot of choices given. Like, this is part of your recovery before we even clear you to go home, kinds of things. Like, that's moving into that whole prescription of exercise, prescription of diet kind of realm. But on the pre side, we don't tend to go there, but just it's more of a curiosity and how that would be received by patients as well.
Thank you.
See that Donna has her hand raised.
I think this is really interesting. And I agree with Chris, because I think patients need to feel or see the qualitative difference that makes to them before you're going to get the buy-in, the commitment to the 3-month program, and then reap the benefits post-transplant, which your study didn't seem to show a difference, which I'm kind of surprised at, because we do know that there's a difference with living liver transplantation and deceased when you may be far sicker before you receive a transplant offer. So I found that a little surprising, but I think you need that. You need that to know that you're doing something to benefit yourself before you're going to get that commitment. And they want us keeping our life normal, which often means working, until I had one friend who, she had hepatic encephalopathy on the way home. She ended up phoning her husband because she didn't know where she was. She was lost. She was 2 blocks from home. So there's a fine line between all this. So I understand what you're getting at. I think it's a fantastic program. I'm just shocked it didn't show more of a difference, because I think there would be benefit to be had, but I think it's a whole package.
Thanks, Donna. So I do agree, and I think what you're describing really well is how to reach out really to our people on the waiting list in terms of the quality of the changes that they might notice, because it would be much more important for you than a number like a 6-minute walk test. That doesn't speak to you, and I think we need to be able to find a common ground in terms of what are concepts that will make your life easier while you're waiting for a liver transplant and have control. So thank you for that. That's really important. Now the comment on so our study in terms of the intervention itself is still ongoing. This was a systematic review, so we had to put in together a bunch of different studies that were done. Only focused on deceased donors. So it's a special population, which, and again, for liver specifically, we did not look here at other organs such as hearts or kidneys. No, but you're absolutely right. And I think we need to be able to adjust the way we talk and the way we offer these programs to a potential participant based on what they'll be able to get out of it. Thank you. Thank you, Don.
I also think part of it is with the liver, at least my experience was, I found my cognition was just grinding down. You tend to lose your analytical, your cognitive function slowly. You got to make it prepackaged for us. We got to make sure that what we're doing for us is making a difference. Because where we expend our energy becomes the major thing. I plan my day around 2 activities because that's all I could handle. I did more than that, I was down for a couple days.
Yeah. Thank you.
Well, I do see that time is just about up here. Thank you everyone for your questions and comments throughout today's presentations. Dr. Benmassaoud, on behalf of the CDTRP, thank you so much for presenting today. If anyone has additional comments or questions, perhaps suggested topics or speakers for future sessions, please contact Erica Croft at ekcroft@cdtrp.ca. Thank you everyone and enjoy the rest of your day.
Thanks, everybody.
Thank you for the
Great
invitation.
job.
Yeah, thank you for the comments. Thank you.